Great. Can you see them? Can you see the slides?
Yes.
Great, perfect. Okay, super. So I am going to talk about how we try to develop mobile health interventions in order to change behavior, now that Donna has told us what behavior is all about. So if I can, well, maybe I can do this. Whoops. Okay. So I want to start off, well, I want to cover three things. First, I want to start off by talking about the context in which we do mobile health. What's the motivation for it? How has it evolved over time? Second, more consistent with what Donna's been talking about, how do mobile health interventions change behavior? How do they work? And then how do we go about optimizing the mobile health interventions that we've got to make them both more effective and more efficient, which has been where most of my work in the last few years has been focused. So in terms of the motivation, what got most of us to use mobile health technology for behavior change is that many of us started off, like myself, I'm a clinical psychologist, so I'm accustomed to treating people in my office for a 50-minute hour, which means that they have to come and drive to where I am, pay for parking, deal with childcare, and it may be that there's nobody who has behavior change expertise around them. So one of the things that mobile health technology, and in fact, digital technology in general, gave us was the ability to overcome some of these kinds of logistical barriers. So people could receive an intervention when they were at home at a strange time of day. If they worked a couple of jobs, they didn't have to pay for parking and so forth. A second reason that many of us shifted to using mobile health technology is because of participant engagement. A lot of mobile health technologies have interactive features that make them reinforcing and keep people coming back to them. They also offer a kind of a connectedness outside of the office visits. So one thing that I always experienced was, so I would see a patient in my office and I would coach them and help them with trying to problem solve some of the behavior change challenges they were going to encounter outside. And everything was fine while they were in my office, and then they would be outside the office, and that's where they would encounter the problem. They never encountered it in my office. So we wanted something that could be a decision support tool, or something that they could take with them that would help them in the moment when they needed help and no interventionist was around. Another reason was, in order to be able to have something to begin to address maintenance, something that we could leave behind, because interventions end and interventionists go away. And it's nice if you have a tool, some piece of technology, for example, that stays behind, because we have big problems with maintenance of behavior change. So this is a step, baby step towards addressing it. The most recent reason, and this is really exciting, has to do with the availability of dense digital data that smart technologies give us. They are recording shocking amounts of information about us all the time. Your smartphone knows things about you that are, I'm not sure you would want it to know. But so these smart technologies have the ability to detect what's going on with us in our real world, when we're at risk, when we might be receptive to an intervention. And that gives them the potential to deliver contextualized smart intervention when it's needed and when we might be receptive. So that's a big deal. It's probably a little bit more promising than delivering at this stage, but it will be delivering before too terribly long, I'm sure. So what do we do about the fact that technology really evolves rapidly? So the close to home example that I always think about in this regard is, when I was in junior high school, my favorite television show was this show called Get Smart, which was about a secret agent who had a love of gadgets. And one of his really cool gadgets was he had a shoe phone. The bottom of his shoe turned into a phone. Well, my friends and I all thought this was the neatest thing, and we all wanted a shoe phone. But never in a million years did I think we would see anything like this in our lifetimes. However, fast forward a few years, and we had mobile phones. Realized that this was when I was watching Get Smart, was the time when phones were attached to the wall, or they sat on a table and were connected by a cord. You couldn't walk around with them. Notice also that the first mobile phones were about the size of a shoe. They were the size of a brick. They were huge. And then over time, they've become smaller and smaller. And similarly, this was one of the earliest smartwatches. This was actually something that Seiko developed in 1980. Very appealing, aesthetically lovely. And of course, now we have much more sort of feasible, attractive smartwatches. So what's going on here that keeps letting things get smaller and smaller? Most of you probably have heard of Moore's Law. Moore was a co-founder of Intel, and he made a very interesting observation, which has held true since the mid-1900s. It's still true. And it's that every couple of years, the number of transistors that you can fit on an integrated circuit has doubled. And with that doubling comes a dramatic increase in processing speed, in memory capacity, and in the number of sensors that you can fit on the integrated circuit. So things can get smaller and smaller because you can fit more and more on that circuit. So we've clearly seen a whole lot of evolution of technologies that we've used in our behavioral interventions. And so here you're seeing 4 generations of technology that we have used. I do work on multiple diet and physical activity change and also weight loss. What you're seeing here up in this upper left corner is the first device that we were using. This was back when Palm Pilots were cutting edge technology. And so you can see we have people doing the diabetes prevention program on this Palm Pilot. They're tracking their saturated fat, their physical activity. We're using the actigraph accelerometer at this time, but because we can't get that device to Bluetooth the activity counts onto the Palm Pilot, people are self-reporting their activity, which we know is inaccurate, but that's all we could do. Fast forward a few years, and now we have Android phones, and we have the first generation of accelerometer that can Bluetooth to a smartphone. So now, in addition to having people entering what they're eating, they now are getting data transmitted from the accelerometer, and you're seeing it in terms of how well they're doing, at meeting their physical activity goals. Then we move along a few years, and now we have iPhones with even catchier graphics, and we have a Fitbit accelerometer that works really well. The prior one, the Shimmer, didn't work so great. It would stop functioning, and you couldn't tell when it has stopped functioning. You had to poke it with a paper clip to get it restarted. And now moving along, we do things in either iPhone, stop that, or Android, and we transmit data from a Wi-Fi scale or from a sensor, and the data are sent to a coach. You see in the center there, who coaches remotely, and sometimes we also have people meet with a group. So all of these techniques are using goal setting. You see that the icons are showing the goal for fat allowance, a calorie allowance, a physical activity goal. People are self-monitoring. They're entering their food intake. They're wearing an accelerometer that's entering their physical activity. They're getting feedback about how they're doing. You can see it in terms of the color codes or how the thermometers are filling up or whether they're closing the circles in the iPhone. And there is also social support and accountability from the group or the coach. So ask yourself, are these the same intervention or are they different? Certainly the technology has changed. It meets the naked eye test. It looks radically different. But are the interventions really different? And now this can come up. I would say that although the technology changes rapidly, it's important for us to remember that the tech, the widget, is a tool. It's not really the driver of behavior change. We are using that tool to apply human behavior change techniques that really have remained pretty much the same or evolved very, very slowly over the course of evolution. So I think more the same than different, but certainly the technology looks different. So I would suggest to you that at least in terms of diet and physical activity change and weight loss, the theory that is the most widely used is called control systems theory, developed quite a while ago by Carver and Shire to describe self-regulation. And the theory graphed here basically posits that in order to self-regulate, you've got to be able to know where you are now, what's your current state, and what's your goal. And you need to be able to detect the gap between those two. And if you do that, then you're motivated to reduce the discrepancy. So basically, it's like you're like a thermometer. Your thermometer has a temperature goal. It detects where the temperature is in the house. And if it's not aligned, it turns something on to adjust and match. So that works fine for a thermometer. And it works fine for other kinds of physical goals like this. If you've got a flat tire, you kind of know that it's not supposed to look like that. It's supposed to look more like this. And so you keep pumping air into the tire to reduce the discrepancy until it matches the goal. But how about if your goal is something like this, a 500-calorie lunch? And how about if your current state, what's on your plate, is something like that? Are they aligned? Are they discrepant? It's a little bit hard to tell, but they're actually fairly close, although most of the times we don't think that. It probably depends on what the condiments are on the hamburger. But you see how the app instantiates this self-regulatory control system. So it prompts goal setting. It reminds you of what your goal is. It shows you with these, the thermometer and the fans. It prompts you to self-monitor because that's what's filling up the colorful fans and thermometer. And it's giving you performance feedback on how you're doing. So really, this is pretty much what most apps do for diet and physical activity change and weight loss. So will it work? Will it work to change behavior when we look at a problem like obesity treatment? So the very first study we did in this area was when we were still using Palm Pilots. And I was very interested in, I was always worried about the digital divide that affects older people. Because I think young people have a fair degree of technology literacy, not so much for people my parents' age or even people my age. And so the first study that we did was with elderly veterans in their late 50s, early 60s, none of whom had ever seen a Palm Pilot at that time. And they were overweight or obese, and they were receiving treatment in the VA's MOVE program, which is a group treatment for obesity that uses dietary self-monitoring, physical activity self-monitoring, and behavior change intervention. And all that we varied was whether people were recording their diet and physical activity on paper and pencil, which was traditional, was what they did in the MOVE group, or they were recording on our Palm Pilot. That's all that varied. And here was what we found. The blue lines are the groups that are recording on the Palm Pilot. Red are those who are recording on paper and pencil. Solid lines are those who attended at least 80% of their MOVE group treatment sessions. Dotted lines are those who didn't, who attended less. So the first thing you see, ask yourself the question of, okay, is it the technology? Is it the widget that's doing the work here? Well, the technology alone is not doing magic. As you see, for the people who had the technology but were not really engaged in attending the groups, if the technology is, you've got it, but it's sitting in a drawer and you're not using it, it's not going to help you lose weight. In fact, these folks actually gained some weight. But if you're engaged in your treatment and you're self-monitoring and you're going to your groups, it gives you a leg up. So you see that the folks who had the technology and were engaged in their treatment lost about 15 pounds. The poor folks who were engaged in their treatment went to 80% of the groups, but recording on paper and pencil really didn't lose much weight at all. They were the people who I think were really quite disadvantaged. So that was kind of cool. Now, can we optimize how efficiently our mobile health technology changes behavior? So I am a big fan of Archibald Cochran, who wrote this wonderful little book in 1972 called Effectiveness and Efficiency, Random Reflections on Health Services. We credit him with having been a pioneer of the randomized control trial, and he's the person for whom the Cochrane collaboration, which is a worldwide effort to do systematic reviews of clinical trials to tell what treatments have a supportive evidence base. His comment was that the demand for treatment will always outstrip available resources. He's not actually the first person to have made that observation. William Osler, who is often called the father of American medicine, back in the 1800s made it. He was somebody who was one of 4 physicians who started the Johns Hopkins Hospital. And in a commencement address, he famously said, well, there is one major thing that differentiates men from dogs, and it is the desire of men to take medicine. Where this desire came from and where it will go is a problem for psychology, which is a really sort of an interesting way to think about things. And I think it is quite wise in terms of the problems that we have with overtreatment and the rampant healthcare costs that we face. So Cochrane's premise and the basis for setting up the Cochrane collaboration was that we really need to only pay for treatments that have evidence that they work, that they're worth paying for. And also that we have to be sure that our health policy maximizes the efficiency with which the healthcare system uses its human and financial assets. Because the fact is, because we want more treatment than it's possible for us to get, we have to be wise about who is getting what. And it should be allocated according to people's need. They should not be getting less than they need, but by the same token, they should not be getting more than they need. And I just find this a profound observation at this time when we have the most expensive healthcare system in the world, and we are about 25th in the world in terms of our longevity. So this is the behavioral intervention that is probably our holy grail in health behavior. It is our most effective intervention, widely replicated. It's called the diabetes prevention intervention. It was an intervention that was developed to treat people with overweight, obesity, and prediabetes. And it was tested in a multi-site, 3-arm clinical trial where people either were given a placebo medication or metformin or an intensive lifestyle intervention, much like I described for the MOVE intervention. And what you see is that overwhelmingly the lifestyle intervention, the behavioral intervention, brought about the most weight loss. And it also most effectively delayed the conversion of people from prediabetes to diabetes. And I then was brought to wonder when I began working in medical school environments, why when I would talk to my physician colleagues about the diabetes prevention program and ask them if they knew about it, they would say, oh yeah, you know, that's the one that showed that metformin prevents the conversion from prediabetes to diabetes. No, it's the one that shows that behavioral intervention is better than that. So why was this happening? I think it has a lot to do with this. It has to do with the fact that, yes, our very effective diabetes prevention program and its successor, Look Ahead, which worked with people who have frank diabetes already, it does work beautifully. It produces a 7% sustained weight loss and metabolic improvements, but it's very burdensome. It takes somewhere between 16 to 36 sessions, and it's expensive. In its original iteration, it cost about $1,500 per patient per year. And so you can see in this bar graph comparison that the lifestyle intervention, when it was delivered individually, was the solid blue lines, really expensive. We could get the cost down by delivering the treatment in groups, but it still costs more than metformin, which is in red, or a placebo in green. So I think it just struck people, it struck the medical community as, yeah, that's very nice, but this is just not viable. It's just not realistic to expect this kind of treatment to be used. And I think this is really the problem that we are left focusing on in health behavior change. And I think it comes from three separate problems. One of them is that the way we have gone about assembling our treatments has been by tossing components into a kitchen sink. We have not known what components of an intervention were working, so we put them all into this big bundle, and we get an effect that works, but we're spending a lot of money, and we don't know what we could pare it back and still have an effective treatment. Another thing we don't know is who needs what. And again, if we're thinking about how to allocate healthcare resources across an entire population, it's probably the case that some people don't need an awful lot of help. They can get by with fairly minimal support, and other people are going to need a whole lot more support. Some people are going to need bariatric surgery, and it's going to cost a lot. Another thing that we don't know, and is another reason why our interventions are so expensive, is when are we done? We know that we can initiate behavior change, but we're not really good at maintenance. So how do we maintain behavior change? We keep administering the treatment by the trained interventionists for years, if we can get away with it. But obviously this increments costs. So if we had some way of telling when we're done, that would be hugely helpful. So there's a very exciting suite of methodologies that was developed by Linda Collins and Susan Murphy, Billy Naim-Shaney. Billy will talk about these later in the week in more detail, but we found that, and I will give you some examples of them. It helps to sort of give you a pre-exposure, and then Billy will go into more depth. And the gist of this is that they take all of these bundled components in the kitchen sink, and they try to sort them out into optimized interventions in three ways. There are three designs that are the most relevant. One of them is the most factorial design, and this gives you, it looks at the effectiveness of the different components and their cost, and it gives you the best optimized average intervention to maximize the treatment impact at the least resource consumption. You can think of this as the evidence-based best practice, or if you're a psychologist, you might think of it as an empirically supported treatment. Smart designs, they're sometimes also called step-tier designs. This is a great design for addressing the fact that we know that people need different things. There is response heterogeneity. Not everybody needs the full load of intervention, but some people do, and more than that. So this is a design for addressing the fact that in behavioral intervention, we have almost nothing that is at the stage of precision medicine, if we have anything at all. We cannot tell before we administer a treatment who needs what. But we're starting with these methods to get to the point where once we start administering an intervention, we can tell pretty quickly who's going to need more. That's what a smart design helps you do. It addresses questions like, where should you start? What should be the sequence you follow? How long do you need to wait to find out if a treatment is working? And what should be your stepping rules if it's not working? How much should you augment the treatment? The Jedi is the most exciting one, and it deals with the fact that, just like SMART is dealing with the fact that different people need different things, the Jedi is dealing with the fact that we as individuals need different things at different times. Like Donna's example of the chocolate craving. Sometimes this is really hard for her to resist, other times not so difficult. So how do we know when people are at the greatest risk and the greatest receptivity to intervention? This is for dynamically personalized behavioral medicine. I am actually not going to go into the Jedi and the micro-randomized trial in this talk because it's too much, we found. Billy will go into them in greater detail. So let me introduce you to a most factorial experiment. This is a study called the Optin trial that Linda Collins and I did together. And Donna, you'll see I've reclaimed my slide because we used it to design this trial. Most of our behavioral interventions work, that you see here the ecological model, most of our interventions work at the individual level. We are trying to equip people with better self-regulation strategies, goal setting, self-monitoring, paying attention to feedback, problem solving, and so forth. And that all of that increases their self-efficacy. That's sort of where we end usually. And so what we varied in this Optin study was whether we gave people a lighter dose of that, we gave them 12 coaching calls and an app, or whether we gave them a more intensive dose of that kind of self-regulation training. We gave them 24 calls. At the next outer layer, we get to the interpersonal level. Here, there are other influences at play having to do with social support or norms. We tapped into this level by having everybody enroll in this trial with a buddy, somebody that they knew, that they brought with them, and we varied whether we trained this buddy on how to be supportive or not, figuring if we left behind a supportive buddy, we'd left something good in the interpersonal layer of the intervention. At the next level, we wanted to tap into the organizational or system level. And I think this is actually where my work is going more now, trying to integrate our interventions into the healthcare delivery system. We could only do it in a light touch way here. We varied whether we sent the person's primary care doc a report of how they were doing or not, with the hope that if we sent that report, when the person went to see their primary care doc, the doc would say, oh, you know, I see you're losing weight, or, oh, I see you're enrolled in this program. And it seems like something is happening, but maybe your attendance could improve a little bit. The outer layer, the policy or environment layer, I think we know is very important. Taxes, laws, the built environment, the food environment, healthcare insurance, these things have a huge influence. We were not able to vary them in this study except by a very light touch. We varied whether we made the food environment easier or not for people by offering them meal replacements like Nutrisystem or Jenny Craig, or not offering them that. Okay, so the primary aim of this study was to identify which of those components I've just told you about contribute the most to the average weight loss expressed as a continuum, or dichotomously, the percent of people achieving a weight loss of 5% or more, which is the public health goal. And our outcome we assessed over a 6-month period. So here you see these components again, and we're varying whether they are at the low intensity level or the on or the off or on. Okay, and here you see, I want to flag for you that what I'm going to present first is this basic question about which components are doing the work and at what cost. But important to bear in mind that when you finish a most factorial trial, you are not done yet. You have 2 things actually to do further. One is that you enter a decision-making phase. The answer is not given to you on a stone tablet when you finish your trial. you can apply different decision criteria to build a treatment package that yields what you want for different constraints. Our constraint in this case started with being we wanted the maximum weight loss that we could get for less than $500 because we knew insurance would pay for that. So how did this design work? Well, a lot of times the question comes up in most factorial designs about how do you have the power to be testing all these interactions? You've got 16 cells in this study. Well, the answer is that basically you're not mostly looking at interactions. You are looking at them in an exploratory way, but what you are really examining is the main effects of the components. And here you see, for example, that half of the sample has got the light level of coaching sessions, 12. Half has got the heavy level of 24. Half have no report to the primary care doc. Half have a report sent to the primary care doc. Half have no text message reminders sent. Half have them sent. And so in each comparison, you're using the entire sample. And given that this is 562 people who are enrolled, that's a lot of sample. This was an entirely remote intervention. The assessors saw these folks to measure their weight loss at 3 and 6 month intervals, but the coaches never saw them. It was completely remotely delivered. So what did we find? Of the 5 components, the only one that had a significant impact on weight loss was the buddy training. If people's buddies were trained to be supportive, they lost more weight. There was an interaction at a marginal level with the primary care report. Primary care report on its own had no main effect, but if the person had buddy training, it bumped up, it augmented that effect. So the thing that blew my mind, I was really bowled over by this, is why didn't getting 24 sessions versus 12 sessions have increased the amount of weight loss? I mean, that's the most expensive big ticket item in the intervention. And usually we know dose response relationships mean that, if you're getting more intervention, you're getting a better outcome. So my first thought was, well, maybe people just didn't engage in the intervention. Maybe they got no calls. But it really wasn't the case. People who were in the 24 call condition got about twice the number of calls, and they got about 100 minutes more intervention. So the intervention was delivered and received. So I've told you the intervention components. Now we move to this decision support stage where we're trying to figure out what is our optimal package. And here you see some options. You see all of the components arrayed by whether they're at the lower level or off or on. And if you are following just the results that I showed you, the intervention that you would probably go with is this combination number 21, which has the buddy training turned on, the primary care report turned on because it's not very expensive and it augments the buddy training effect, but everything else is at the lowest level. Why would you turn something on that costs you a little bit of money when it's not doing anything, not having an impact on weight loss? And that is a nice intervention. It costs you less than $500. It's $427. It gives you a clinically meaningful 7% weight loss in at least half of the population, and it's a decent value. It's about $75 per kilogram lost. That's the optimization criteria that we selected when we designed the trial. But there is another way to think about this, which is actually more consistent with the Cochrane view, and it is this latter one. If my optimization criteria is that I'm running a federally qualified health center and I don't have much of a budget and I have a huge population of people that is obese and pre-diabetic who need weight loss treatment, how can I spread these dollars around to reach the maximum number of people that I can produce at least a public health benefit for? And you'll see that a very reasonable option in that case is to just keep the 12 coaching calls and the app. And don't turn anything else on. Don't turn on the buddy training. Don't send anything to the primary care doc. If you do that, you get about 1 kilo less of weight loss, but you still get half of the population achieving a public health 5% weight loss. And that saves you about $100. You can deliver that intervention for $324, and it's an even better value. It's about $67 per kilo. So this is a very good news story for public health. Now for the SMART trial. This is the one you remember where we're trying to deal with between-person heterogeneity, the fact that we know that some people don't need very much and other people need a whole lot. How do we figure out who is who? And this, again, you see my my mantra here. This is an editorial I wrote a few years ago. I really think that we will have sound healthcare economics when we can figure out the way to give people the treatment that they need, not less, but also not more. This SMART trial I did with Billy Namshani, who will give you a lecture on all these designs, maybe tomorrow, I think. And here was the problem that we tackled in this SMART study. We had two primary aims. The first question was, what's the best first-line treatment for a population of adults with overweight or obesity? Is it better to start with just an app alone, or to start with the app plus coaching? Now, obviously, the app plus coaching costs a whole lot more. The app alone costs a whole lot less. But if you found, for example, that you couldn't recover the people that you were wrong about who started with just an app alone, and they got demoralized and you couldn't bring them back, it might be better to start with an app plus coaching, because the cost of being wrong was so high. And then the second question was, in the case of weight loss treatment failure, is it better to modestly step up by adding an inexpensive mHealth component, in our case, text messages, or to vigorously step up by adding both the mHealth component and a traditional, more expensive weight loss component, like coaching for those who haven't had it yet, or meal replacement who have already had coaching? Something that you would ordinarily have to do before you got to being able to do a SMART design is you would have to look at the question of how long do you need to wait to know if the treatment is working. We had a leg up in this case because we had preliminary data that showed that we could predict by looking at somebody's weight loss after 2 weeks, how they were going to be doing in terms of their weight loss at 6 months. We gained essentially no new information after 2 weeks. And actually now, by applying a machine learning algorithm to the data from the SMART trial, we can actually predict at the end of 1 week whether somebody is how they're going to do by 6 months. So here is the design. You see the first randomization, we begin by giving people just an app or the app plus coaching. And we then let them go along and we check on them every couple of weeks. We check on them at 2 weeks. And if they're doing fine, we let them continue with whatever they started with. We check on them again at week 4. If they're doing fine, we let them continue. And we check on them for the last time at week 8. If they are doing fine, we let them continue to week 12, where we stop the treatment. If they're not doing well, we re-randomize them only once at the first time where they're not doing well. Now, what do I mean by not doing well? In this first trial, we operationalized it by whether they were losing a half a pound a week, which is, for commercial weight loss programs, considered a safe rate, both an effective and a safe rate of weight loss. This trial involved 400 people. You can see that for app alone, if they were not doing well, we re-randomized them to the modest step up by adding text messages, or to the vigorous one by adding text messages plus coaching. And if they started with app plus coaching, we re-randomized them by adding the text messages for the modest augmentation, or meal replacement for the vigorous one. So think for a minute first about, who do you think will do better in this trial? I mean, I think this sort of The common sense way of thinking is that'll be the people who have App Plus coaching. I mean, they're getting a much more expensive intervention. You're paying for human interventionists. Surely it should do better. So we look at this first by what percent of people who started being randomized to app alone versus being randomized to App Plus coaching needed augmentation. We're not doing well, so they needed to be boosted up. And this is what we found, which once again, these designs, they really blow my mind. I always am so surprised by some of the things they show us. In this case, regardless whether we started people with just the app or the App Plus coaching, about half of them did fine just fine. They didn't need any additional augmentation. Whoa, who would have thought that? Now, when we actually look at the weight loss at 6 months, in fact, what you're seeing here is the people who started with the app alone. Here are the people who started with the App Plus coaching. And what you'll see is that there was somewhat greater weight loss among those who started with the App Plus coaching. There was actually an augmentation of weight loss of about 4.3 pounds more. But we had preset a non-inferiority margin, which said, look, you've got to give us a clinically meaningful benefit for us to say it's worth the cost of implementing the more expensive treatment as the first line best practice. And it didn't pass that non-inferiority margin. So on this basis, we would say, well, if you're going to do stepped care, it's a reasonable thing to start with just an app alone. So the last thing I'll tell you about is where we are going now. The current thing that we're dealing with, we have a grant to do secondary analysis. This is a grant we call the BEAM grant, shining a light on behavioral acquisition and maintenance, because our premise is that if we could figure out when we have got a durable behavior change, maybe we could stop doing behavioral intervention forever at a cost of monstrous amounts of money. And similarly, if we're in the maintenance phase where we have faded treatment, we're not doing it anymore, do we have a way to tell when the behavioral habit is becoming wobbly, so we need to reinstate intervention? It's like a Jedi, an augmentation on the fly. We're being able to do this, and this is actually, you remember I told you about the transdisciplinary finding that we had developed a new mental model that I could no longer communicate to my behavioral colleagues. This is that grant that we developed with statisticians and computer scientists. We're able to do this because we have 6 randomized controlled trials that involve changing diet and physical activity, some just doing that, some doing it in the context of weight loss. We conducted these trials over 14 years using 1,600 participants. And because this is big data, we've got 147,000 daily data points, which of course we had aggregated before into weekly synopses. And now we are disaggregating to take advantage of all of that information. Our hypothesis, and I have no idea if it's right, is that the induction of a durable behavior change will require both an improvement in what we call the location, the mean, which is what we usually measure in our interventions. It involves an increase for healthy behaviors like increasing fruits and vegetables or physical activity, a decrease for unhealthy ones like eating excess calories or saturated fat or watching too much TV. And the new thing that we're looking at is we also think it will involve a decrease in scale. So this is using location scale modeling techniques where scale is a measure of behavioral consistency. We have been able to measure that at a between group level. Part of what this grant is doing is extracting a way to be able to measure scale, behavioral consistency over time at an individual level. So we will be able to tell when somebody has both improved their location and improved their consistency. And we're predicting that that's when they will have achieved a durable behavior change. We also are plugging in these new variables from the location scale models, using machine learning to derive algorithms that will help us make real-time decisions about when we can stop administering treatment, how much treatment duration do we need. So just to conclude, I would suggest that technology-supported interventions have helped us expand the reach, reduce the burden, and refine the tailoring of behavioral interventions. I also think it is not the widget that is alone doing the work. It only works because it harnesses effective behavior change techniques. So it is really why we need a transdisciplinary field here that involves both the technology and the behavior change understanding. These new research designs in the multi-phase optimization strategy can help us optimize interventions systematically and I think efficiently. There are 3 designs that are particularly relevant for you. One is the most factorial, that will give you the most efficient and effective intervention package for the average person given certain constraints. Then the smart designs, which help you develop step care decision rules to address differences between people in their treatment response. What should be tried first, for how long, what should be tried next, and what should be the protocol for weaning people off of treatment. The last thing, which Billy will talk more about, is these tailoring rules that specify when and how to address within-person changes in state. Mostly JEDIs and micro-randomized trials have been about rapid changes in an internal state. The example of stress, of craving, that's there 1 minute and not there the next. I am also interested in these more plateau-like changes, like the acquisition of a durable behavior change that we don't think will be gone the next minute. We hope it will stay around for a little while, which is what will make it, I think, a better basis for stable decision-making. So I will stop there. I need to acknowledge my funders and my wonderful lab team, without whom none of this would get done. As Linda Collins and Billy Namshaney, collaborators up in the upper right-hand corner, and my wonderful group of collaborators at Northwestern, Don Hedeker, the statistician, Nabil Al-Sharaf, our computer scientists, and Angela Famater, my behavioral intervention colleague. So thank you very much.
So when you were showing that it didn't, about the same amount of people responded to one thing or t'other, what do you know about the characteristics of those people? Is it different types of people?
No, we cannot identify. I mean, and I think this is very characteristic of the weight loss literature. It's the Yanofsky's premise that the only things that we know predict success at weight loss are your starting weight, because the bigger you are, the more you will lose, and your early success in treatment. So it is why I mean, this is probably the best literature we have, and yet we can't get to precision medicine where we can do treatment matching ahead of time. We need to start the treatment and then look at the early characteristics to
do you have anything like personality on these people?
We have lots of personality data, and we have demographics.
And none of it matters?
Excuse me, nothing so far has worked. I was particularly disappointed in the demographic data, and this actually may have changed. We analyzed this for a conference partway through, but I was hoping that this approach would overcome the usual demographic differences we see, where men lose more weight, minorities lose less. And I forget the other one, at low education lose less, and those persisted.
No, but I'm trying to understand if certain people responded better. So it's 50%. Is it a different 50% depending on?
We can't figure out how they differ. It's exactly the question we should want to know. And it is part of the reason why I think we see these most designs as building up that evidence base. So maybe if we have adequate sample, we can get a sense of who those people are, but we just don't know.
Bizarre.
Yes, bizarre.
And very cool.
But we'll stay employed.
I'm not out of a job yet.
Yes.
I put my email in the chat if people want to chat with me.
Oh, I can do the same. Yep.
And thank you for letting us keep you 11
Yes,
minutes.
thank
over.
you. Sorry about that.